I may introduce our next speaker, who is Dr. Gregory Haber. He is the expert's expert at NYU in Langone, and he's going to speak today on the really difficult and defiant bile duct and pancreatic duct stones. Thanks, Greg. Thank you, Norio.
Yeah.
Thank you.
Thanks, Greg, for the introduction. And, it's just such a pleasure for me to be speaking with moderators like you and Rob and alongside Norio as a speaker. It's a great pleasure for me to be doing this. And also, Haru Anui is an amazing man, and to be able to put together this phenomenal course, bringing together people from around the world, it's heartwarming for those of us who miss the meetings and meeting up with colleagues and part of our CME to learn from our colleagues. And Rob and I go back a long way to the days of Seoul, Korea, and we became Seoul brothers. And so that it's great to revisit this, Rob. So let's go ahead with the talk. I'll see how it turned out. I'm not sure. Hello from New York City. It's a great pleasure to be able to present at Tokyo Live 2020 with the leadership of Professor Inoue and with a tremendous team in Japan helping to put on this meeting. I've been asked to present on difficult stones, and I'd like to focus on challenging stones both in the bile duct and the pancreatic duct. The first question is, what's a difficult stone? There's no question that size presents a challenge, location in the liver or in the cystic duct, calcification, which may not be recognized by everyone here with respect to the difficulty and the hardness of a calcified stone, and then finally getting stones out when you have a downstream stricture or narrowing of the distal bile duct as it traverses the pancreatic groove. So what are our options? Of course, there's a traditional sphincterotomy, and in the last decade, the sphincteroplasty has become an essential part for difficult stone removal. And then old standbys like mechanical lithotripsy, intraductal lithotripsy, extracorporeal shockwave lithotripsy, and finally stents as a bridge for the management of stones which are not easily removed. The game changer really in the last decade has been the use of sphincteroplasty, either alone or as an adjunctive treatment following a partial sphincterotomy. I would like to bring you up to date on the current use of sphincterotomy and sphincteroplasty and how they can be combined. Several recent publications have looked at these modalities with comparisons of balloon dilation alone versus sphincterotomy alone, and then the combination of balloon dilation and sphincterotomy versus sphincterotomy alone, balloon dilation and sphincterotomy versus balloon dilation alone. First, we'll look at the comparison of each modality on its own. This is a cumulative meta-analysis published last year, and basically it updates the meta-analysis with each new publication added each subsequent year that it's performed. And basically the results of this cumulative meta-analysis are shown as follows. If we look at studies done after 2004, balloon dilation was equivalent to sphincterotomy for stone clearance in the first session. This improved clearance has been attributed to the use of larger balloons in the later studies. And with the use of larger balloons, there's been less need for mechanical lithotripsy. Overall, we still have to say that post-ERCP pancreatitis is more common, but less of a difference when larger balloons were used in larger ducts, and also when balloon dilation duration was greater than a minute, so that the longer the duration of inflation of the balloon, the less the risk of pancreatitis. Interestingly, when Asian and Western studies were compared, post-ERCP pancreatitis was actually not more common after balloon dilation. And finally, with balloon dilation, there were lower rates of bleeding and cholecystitis as expected. One advantage of balloon dilation, leaving the sphincter intact, is a reduced incidence of delayed stone formation. Here's a study that looked at recurrent stones, a median of 6.7 years after sphincterotomy or balloon dilation. And we can see that the recurrent stone formation was almost twice as frequent after sphincterotomy at 17.4% compared to balloon dilation at 8%. Well, if sphincteroplasty has done well, what about the combination of sphincterotomy plus the balloon dilation versus sphincterotomy alone? And in this meta-analysis published last year for large stones, these are stones that are greater than 10 millimeters, there was no question that the combination was better than sphincterotomy alone. Odds ratio for stone clearance being 2.07 initially and overall 2.68. Fewer complications at an odds ratio of 0.63. Less need for mechanical lithotripsy and shorter procedure time. Well, the combination certainly was better than sphincterotomy alone. What about compared to balloon dilation alone? This study was published last year. It was quite a good study from 4 Korean centers with 100 patients randomized to each arm of the trial. And we can see that in terms of outcomes, technical success rate, initial success, overall success for stone removal, the need for mechanical lithotripsy, no difference at all. So what's the need for sphincterotomy, I guess, if the balloon dilation alone had such equivalent results? I have to say that I expected perhaps the complications to be greater, but that was not the case. But I think it's important to emphasize, especially for the Western audience, that this study was carried out in patients with large ducts, up to 30 millimeters in the balloon dilation arm, up to 45 millimeters in the combination arm, and in older patients, only one patient below the age of 60. So this study applies to a particular subset of older patients with larger ducts and larger stone disease. So what's the takeaway from all these comparisons? I think there's no question that the best technique for very large stones is the combination of sphincterotomy and balloon dilation. If you have small stones and smaller ducts, sphincterotomy is still the procedure of choice. If you are in Asia, balloon dilation alone remains a reasonable alternative. But again, in patients over 60, ducts larger than 10 millimeters, and balloon duration of greater than 1 minute. In patients with increased risk, such as coagulopathy, altered anatomy, and periampullary diverticulum, balloon dilation alone is also a reasonable alternative. Regardless of the modality that you use for the index removal, there will always be a need for mechanical lithotripsy in large stone disease. And mechanical lithotripsy is simple, it's very effective, with the only limitation being the ability to trap the stone. In this video, we can see a fairly large stone in a dilated duct, and initially we'll perform a combination of the sphincterotomy to about 50% of the size of the papillary mound, followed by balloon dilation, which is determined by the size or the diameter of the lower end of the bile duct. In this case, the duct is approximately 15 millimeters, and we're using a 15 millimeter balloon to dilate up the opening. And then once we have the opening, we'll pull out whatever stones can come through intact. But if we are faced with yet larger stones up the duct, which are somewhat bigger, rather than get impacted, we're going to use a mechanical lithotripter. So we're going to trap the stone in the large basket of the mechanical lithotripter, and then we can slide the metal cable over the plastic sheath of the basket. The metal cable goes up to the base of the stone, and then we can gradually close that basket against the rigid metal cable and crack the stone into pieces, which will allow for clearance of the duct. I do think it's important to point out a particularly difficult stone, and that's the stone which is either fully calcified or has rim calcification. And if you look at this stone, the plain film shows clearly a densely calcified stone, and this was in a duct which was quite narrow as it traversed the pancreatic groove. So we decided and opted to use mechanical lithotripsy, which you can see here. However, much to my surprise, 32 individual cables of the mechanical lithotripsy wire, and you can see the cable here telescoping on itself, completely broke against that calcified stone. And ultimately, we had to go to extracorporeal lithotripsy to help break up the stone to remove it. However, more often than not, we move to intraductal lithotripsy using either electrohydraulic lithotripsy with a spark gap probe, generation of about 7,000 volts, and creation of a plasma and then a shock wave, or a holmium laser. The game changer for intraductal lithotripsy is really the single operator cholangioscopy. This is demonstrated in this video, in which we'll see calcification on the rim of these stones within the common bile duct. Initially, we like to do balloon dilation to facilitate passage of the cholangioscope. And once we advance the cholangioscope, we, of course, will treat the lowermost stone first. And as we clear out the stones lower down in the duct, we can move back up the duct. And you can see here the difficulties encountered cracking this stone because of that calcification. But with continued application on the periphery of the stone, we eventually crack through and clear this stone out altogether. In the interest of time, I would like to move on to pancreatic duct stones, because I think these are challenging and very interesting. The first case report of removal of a pancreatic stone actually came out of Japan. And at the time, it was almost heresy, because cutting the pancreatic sphincter was considered a sure way to get a terrible pancreatitis. However, this was a lesson that it could be done, and subsequently it's become standard of care for many pancreatic stones. Here we can see a floating stone in a pancreatic duct that could be trapped and could be easily removed. The pancreatic stones tend to be quite hard and are made up of calcium carbonate. Factors favoring endoscopic removal of pancreatic stones include 3 or less stones, absence of impaction, smaller diameter stones, a stone which is downstream in the head or the body, and the absence of a stricture. Unfortunately, these features apply probably to only about 10% of pancreatic stones. I can show you some of the problems encountered when we attempted to treat a larger stone. Here's a grossly dilated pancreatic duct. Certainly, we could catch the pancreatic stone, and we were using mechanical lithotripsy in the pancreas to try to break up this stone. But in spite of trying to break it up, the basket snapped, it broke. We had to use a rescue lithotripter from Sohindra. And I'll show you at the end of this video, if you look at what happened, that solid rod of that handle snapped because of the hardness of the pancreatic stone. So I have this little picture of a diamond to indicate how difficult it actually can be to break some of. So that's why we have moved now towards extracorporeal shockwave lithotripsy as the mainstay of the treatment of pancreatic stones. So what are the principles of shockwave lithotripsy? Limit the treatment to stones in the head and proximal body. Target main duct stones using a stent guide if you have diffuse calcification and don't know where the stones are. The use of secretin may enhance the shock effect with increased fluid around the stone. You have to make sure you don't have calcified vessels in the path of the shock wave. If the stone is very dense, as I've shown before, greater than 820 Hounsfield units, you may have difficulty breaking it up. Strictures obviously limit the clearance, and you may have to use stents. And if you can get complete pulverization, ERCP may not be necessary. I would like to go on to the results from the Asian Institute of Gastroenterology, which is Nagi Reddy's institute in Hyderabad, where they have the largest experience in the world for S-well therapy of pancreatic stones. Here's a summary that was published a few years ago of 2,779 patients. So what are the results of S-well? 80% complete clearance, 13.8% partial clearance, 68% could be cleared in 3 sessions or less, with 81% short-term pain relief, 60% long-term pain relief, complications very limited at 4 to 7%, and recurrent calculi in 23%. I think these results can pretty well sum up what you can accomplish with shockwave lithotripsy. The option to extracorporeal, of course, is intracorporeal or intraductal lithotripsy, and this again uses a cholangioscope along with laser lithotripsy or electrohydraulic lithotripsy, which is very effective in select situations. So let me conclude, as my time is now up. Understanding the role of sphincterotomy and sphincteroplasty, either as monotherapies or combined, allows for optimization of stone removal. Intraductal and extracorporeal lithotripsy, these are mandatory tools if you're working in a tertiary care center and you're handling the most difficult stone disease. There's no question now that cholangioscopy and pancreatoscopy have provided access for application of these disintegration therapies and help for removal of stones. And finally, if you're dealing with pancreatic stones, there's no question that your basic basket and balloon tools will not work, and you'll have to have access to S-well therapy. Thank you very much for your attention, and I'll be happy to take questions.
Thank you,
Very
Greg.
well done, Greg. Very, very well done. I think one thing that at least from my perspective, is important is really looking at the distal bile duct. And in those cases where there's a significant dilation right down to the papilla, those are relatively straightforward. To me, the really difficult ones are to have a large stone, maybe a 1.5 ratio of stone to distal bile duct diameter. And at least according to our study, those patients were better dealt with by single operator cholangioscopy and either laser or EHL lithotripsy, as opposed to crushing the stones with mechanical lithotripsy. Any comments on that? Do you look at the distal bile duct diameter, the intrapancreatic portion of the bile duct, and then use that to make a decision about how you will fragment the stone?
Rob, listen, that's an extremely important thing to bring up, and I'm glad you raised that because that is where people get into trouble. I don't know if you remember the RCT that Jim DeSario led up about a decade ago of balloon versus EST, and they had actually 2 deaths related to a standard use of an 8mm balloon in smaller ducts in younger women. So this was a terrible tragedy, and everyone felt it, and it reverberated around the community. And we stayed away from balloons for a good decade after that because of that great fear. So you're absolutely correct. You must assess the diameter of the distal bile duct, and that will determine what size balloon you can use for sphincteroplasty. And I always consider it a concern when somebody presents with cholangitis or obstructive jaundice, and you get down to the duodenum and the papilla looks perfectly normal. There's nothing impacted there. But when you do the cholangiogram, you see a stone about midway up the duct. It's stuck in the bile duct just outside the pancreas where the duct narrows down. And again, you bring up a very good point. It's very difficult to break those stones. I have to say that I have not given up mechanical lithotripsy. If it's a round stone, which is an indication of a softer stone, it doesn't have square edges, if it's easily trapped, I would probably go with a mechanical lithotripter first, Rob. But I would agree that you have to have as a backup your cholangioscopy and EHL or laser lithotripsy. So all good points. But I think balloon dilation is still, it's got a very important role to play, but with great respect to the bottom end of the bile duct.
Comments from any other questions, Greg or Norio?
Yeah, Greg, I'm interested in, we had stopped doing extracorporeal shockwave lithotripsy 20 years ago and then reintroduced it about 3 years ago. And it was mostly made possible by vendors who you could contract with, and they would bring their ESWAL machine in, and we line up a half a dozen patients and we treat them maybe once a month, and it's kind of revolutionized the way we're approaching our patients with chronic pancreatitis. You're shaking your head, being familiar with that. Is that the way that you guys are employing things as well? And is that just here in the United States, or do you know if it's been exported?
Well, you're right. I think what's made it possible in the U.S. is that on the renal side, I mean, our nephrologists have basically been adapting to these mobile shockwave units that they'll bring into your endoscopy suite for a day or a morning or afternoon. They'll basically rent them out, and that's what we're doing too, Greg. We do it, as needed. Line up 2 or 3 cases, and they'll bring it in for an afternoon, and we'll do it. I mean, there are some limitations, I have to say. And the limitations are that, at least in New York State, I don't know how this happened, they limit the number of shock waves to 2,500 per session. And even though we go to the maximum KV, which is about 26 on these units, 26 kilovolts, we still find that it takes longer to break up stones than I feel it should. In most of the units in Europe, and certainly Jacques Devier's unit in Brussels and Nagy's unit, and there are others, they have their own lithotripsy machine in their endoscopy suite. So, and they do lithotripsy sometimes without any sedation. So in India, it's like you're going in for physiotherapy on your shoulder. You go in, you open up your shirt, you lie down, you get shocked for 20 minutes, you go home, come back the next day. So because the average number of shock waves to break up most stones or to clear the ducts is around 10 to 12,000 on average. So the number of sessions is usually 2 or 3. And for us, because we're limited to 2,500 shock waves, we even have to have more sessions. But honestly, you can't live without it. I mean, you can't treat pancreatic stones without extracorporeal shockwave lithotripsy. The great majority are really impacted.
Yeah, I think that is the problem, Greg, in the United States. There are 2 issues. One is Greg's, the limits of the number of shocks, but more importantly, the machines that are used for pancreatic stones are basically renal machines. And if you talk to Jacques and you talk to Nagy, they actually require a much more powerful machine. So I don't, it's a tricky issue here. If you've got somebody who needs 6 sessions to, partially clear their stones or whatever, that's a heavy economic burden. And the reimbursement is also, I think, an issue in the United States. I think we're way behind with ESWL and pancreatic stones in the United States for a lot of reasons, I think.
I mean, the alternative for most of these patients is a pancreatic duodenectomy.
Yeah.
So,
Either
That's where things parse out.
it's
Yeah.
a post-O or a resection. I agree.
Yeah,
Okay,
I mean,
Greg, I think we'll move on here, my friend.
right.
Thank you very much. Fantastic summary of difficult bile duct stones.